First question.
Hi, Tintin Zhang, patient advocate. And I have a question regarding the bacterial microbiome signal from Dr. Riquelme, and also with the neutrophil signal seen from the work from Dr. Haejin and Dr. In. So these two, are we seeing any inflammatory or these opportunistic bacterial infection correlated with implications on the further progression of the disease or not? Like when I was looking at the data set, I was just wondering about that.
Thank you for your question. It's not the inflammation is not relevant in this case. HP positive patients have a high score in terms of inflammation in the mucosa. This is more related to the Olga and Olgim 3 and 4 stagings. 93% of our cohort is HP negative at that time. So what happened is we still have 50% of progression to gastric cancer, even if you are not infected with HP. So our main interest is to see if you have a sort of pattern in terms of the microbiota dysbiosis. And what is in our preliminary results is you have high abundance of Streptococcus. There is new information about the Streptococcus aeruginosus, which is related to specific mechanisms driven to carcinogenesis. And the other thing is Limolactobacillus. We have overexpression of PD-L1, so it's related to some other mechanisms that are involved in gastric cancer progression. So I think it's still an ongoing process. It's not fixed. And Rob have another information that is relevant related to microbiome analysis in terms of the saliva. So if oral microbiome is also related in some patterns that are not the same that we saw in the stomach, but is still not in a point that we can use it for clinical practice, but I think it's going to give us a very useful information to move forward in terms of intervention.
Everything he said. But from a pathology standpoint, I think that the neutrophils were just a part of how you stage the Olgim. So that's why that was coming up there.
Great, thank you. Dr. Lee?
Thank you all for the excellent talks. Jeff, I have quite a few questions, but for the sake of time, I'm going to ask only three questions. First question, Dr. Chan, and very interesting talk about ORF1P. My question is that the de-repression of the line 1, is there any correlation with the microsatellite status, MSI status?
No, they seem to be independent.
And you don't see any difference in terms of like MMR stable or not unstable cancers in terms?
No. It appears to be it's interesting because it has been shown to be a factor in multiple cancer types, but in particular cancer types where there is a loss of P53. So, but not microsatellite instability. And I think that in our colon data, it actually looks to be more associated with chromosomal unstable cancer.
I see. Great. And the second question is that I noticed you combined gastro and esophageal cancer together.
Yeah.
Did you separate the two separately, analyze them separately?
We haven't done that yet. So the study that we had in Cancer Discovery combined the two because that was sort of our initial pilot work in the two cancer types. But our next phase study will be entirely gastric and will be several hundred just gastric cases without the esophageal component. But we're also looking at esophageal separately.
I wonder how this is going to be useful for hereditary diffuse gastric cancer because, even they have a mutation positive, 80% of this, we're going to find some signal cell already on biopsy. So I wonder if you find positive cancer cells, how's it going to change the clinical management in terms of the...
Yeah, so as I mentioned, I think the big unmet need with respect to hereditary diffuse is the fact that, you have such a... you don't really have a clear precancer in most of those cases, and it's like small nests of cells. So we are, in addition to dividing up gastric from esophageal, within gastric, we want to look at the diffuse type separate from intestinal type, because I think the signals will be different, and we probably need to have an even more sensitive assay. So Mosaic, which is the most recent iteration of the assay, takes a little bit more blood and is a little bit more sensitive to smaller levels of protein. So I think we're hoping that that will be sufficient for something as subtle as hereditary diffuse, but we only will know once we look at a substantially large cohort of hereditary diffuse. And hereditary diffuse is rare enough that it's hard to get a large enough cohort, but that's one of the sort of advantages of having kind of this network we've developed, including multiple sites that have a substantial component of hereditary cancer screening in their clinical care.
Just one quick question for Dr. Haejin, for Dr. In. So I wonder, this is a very small sample study. I of course, I thank you very all for the efforts getting this done so far. And I wonder whether you're going to narrow the selection criteria to even higher risk patients so that you can have some more positive results in the high risk category. I'm just curious, because if you have a pretty low threshold, you're going to have kind of low prevalence detection of those conditions. It's also learning from lesson for me to design my own study. So you have to really find a high risk population to screen.
Yeah, I think that for this pilot, at least, we focused on feasibility. And so really it was to understand how people enroll and, who says yes, who says no, and whether or not people are actually willing to do it. So you sort of need to start with a large sample size to do even that. And with a pilot, I don't want to be dragging this out for years, although already I've been dragging it out for 2.5 years. So that's one of the biggest reasons why we didn't really limit it. I do think that there is some opportunity to have a narrower cohort of high-risk people, so that when we're actually thinking about trying to understand the prevalence of or do treatments on, to do it as a enriched cohort of people. I agree.
Thank you.
Yeah, thank you. Congratulations as well for the conferences. Just a question for Dr. Chan, could be for Dr. Chin as well. It's about a slide that you put in where you present the plasma ORF1P. And in the bottom of that biomarker bad cancer says that the patient was thought he was healthy at the moment that you get out the blood, and then he discovered he has cancer. So I think everybody that is here, we're concerned about to prevent. What is the point to do the biomarker if he already has cancer? So I'm wondering if it's just plasma, can be this biomarker tested in the cordon umbilical blood? Because at the end you can just centrifugate it and test there the biomarker, and with that you can prevent the cancer now that you have the biomarker. Thank you.
Yeah, that was, I didn't have a chance to go into detail on that particular slide, but when we did this sort of pan-cancer study, we looked across different groups of people with cancer, including early stage, as well as the control group that had no cancer. We just was interesting, there was one outlier case in the control group which had a very high ORF1P level, and so we were surprised to see that in the control group. But actually, later it was found that that person had an early prostate cancer. So we just wanted to provide that as additional context for maybe why that was such a high outlier. But I totally agree. I think we want to, and as Chin mentioned, I think whenever we're developing these kind of early biomarker tests, initially the way to do it is to do a nested case control where you do cases compared to controls. And largely we want to do cases of early stage cancer because we want to pick up early stage cancer ultimately with the blood test. But the next step after showing feasibility and that the test performs well is to do a prospective analysis like what I heard about today, where you look at people where you are pretty sure they don't have cancer, and then you'd measure the biomarker and then wait over time to see whether a cancer develops. That's going to be a much larger, much more expensive, ambitious study, but ultimately we hope that any of these biomarker tests will get to that level, that point of the testing.
Yeah. No, I just wanted to just add, part of the reason ORF1P is so compelling is that there is a mechanism which, instead of a black box, as I mentioned, but Right now, it's just a protein, but we're in the world of transomics. For example, I think Exact Sciences, if you look at their stool DNA test, it's a hodgepodge of genomic and proteins, the whole gamut. So that could be. We're just concerned. I think Andy's approach is good in that there's high level of specificity that you're not getting false positive. Although, if you have a marker that is what do you call it, elevated in multiple cancers, then there's this issue of where did the signal come from? But at this point, and so we really need to be careful about specificity if you're worried about false positives and the hunt for a positive down the road. But so there's this tension between sensitivity and specificity. The only thing we've learned from colon cancer is in colon cancer, colonoscopy, the goal is to prevent cancer, so the target is an advanced adenoma. So is that similar in gastric cancer? Is our target high-grade dysplasia or dysplasia that we can remove with ESD? And that's going to be much harder to do, and I think that's why Andy's going for a stool model. To get that into the blood, I think is going to be a much higher level, especially if it hasn't gone through the submucosa into the basement membrane. Yeah.
Thank you.
Thank you. One comment along those lines. Where in the progression do you start seeing line 1 increase? Do you see it in intestinal metaplasia?
So we haven't looked at gastric intestinal metaplasia. That is something we want to do in the near future. We've looked at it in Barrett's. So I showed the data in Barrett's. It does seem to be progressively overexpressed from normal to non-dysplastic Barrett's to low-grade dysplasia, high-grade dysplasia, intramucosal cancer. So that progression in Barrett's is very promising. We hope we'll see something similar in gastric.
Thank you. So the question has to do with using race, and in this country at least, race is a surrogate for social economic determinants, and I haven't heard much or anything really said about taking into account the social economic factors that may predispose to gastric cancer. Can someone comment on that?
Yeah, no, this comes up, this is appropriate, it comes up quite a bit. My response to this is that we don't have a good way to identify, and yes, race and ethnicity will probably just be a proxy, and when you adjust for social determinants of health, it might drop out, but there is nothing better at this point unless I hear differently. So
my
it's a
concern is,
start.
at least in this area of the country, more and more people are multi-raced, and that's increasing, so pretty soon you won't have many people who are one race.
Well, so you probably know there's been a lot of effort to try to differentiate race from ancestry and ancestry-specific markers. I think we're limited by our data sets, and so our data sets don't have data on ancestry-specific markers or genetic markers. So there very well could be, susceptibility differences by ancestry, which is more specific and more potentially biologic than using race, where I think, there is all these other issues around what is race really a marker of.
Hi, thank you for your talks. I have a question for Chin and Dr. Chan. So we have so many different ways to detect cancer. We can detect protein levels, antibodies, cell-free DNA, et cetera. And there's more than a dozen of companies that do this. And your group, how do we actually use this in clinical practice? So let's say we have multiple tests that have similar sensitivity, specificity numbers. Do we use them in conjunction with each other to detect protein levels and cell-free DNA together, or do you envision one of them kind of beating out in the race to be the test? How do you see that?
Yeah, I mean, kind of like the Cologuard analogy. Eventually, if you want to improve performance, you would use any omic you can that can improve area under the curve, area under the ROC curve to improve prediction. But there's a lot of caveats with that. What if it's just an association? It's not really. And again, going back to the more biologic mechanism we have, the more we know about that it's a real association, and that it's applicable even across a new population. The generalizability, it really helps having that. But for example, the Exact Sciences, They have the Hopkins study with CancerSeek. Very different model. And then they follow with PET-CT, whereas Grail's technology of the 50 cancers, they use the methylation markers. They say there's a high level of specificity for the tissue of origin for 50 cancers. But apparently it's arguable. But Exact Sciences is working on a version 2.0, for example, CancerGuard, I think. And I think they're going to go with the Cologuard type model, where they look at multiple omic markers, not just methylation markers, but also proteins and RNA. I think microRNA, that's a GastroClear. There are benefits because it's stable, whereas I don't know about the protein, but the protein markers. But there's benefits to different types, and like I said, if you wanted to use all three eventually, that could be the way to go.
I think briefly, one thing we have to differentiate, though, is the use of these tests in a very average risk, low-risk population versus a high-risk population. I think with respect to liquid biopsy, I think the stage is set for developing a test in a high-risk population, either defined by some of the criteria we talked about yesterday for intestinal type or defined genetically for hereditary, because then you have a very high pretest probability of cancer, and you need some option for early detection to risk stratify. And one thing I didn't mention is that this ORF1P test is actually very inexpensive because it's detection of a single protein by ELISA. So it's a very cheap way to initially risk stratify people as opposed to endoscopy or as opposed to some of the more expensive techniques. So I think we have to start with thinking about high-risk populations defined by clinical characteristics, start with some screening tests there before we even think about broadening it to a general population.
Thank you very much. I hate to be the downer here, but I think we have to cut off the questions now. Is it a quick question?
Well, I can put it very quick.
Okay.
Thank you very much. So the question is, with all these very exciting opportunities, starting with these, I'll call it the liquid or the non-invasive screening, combined with the modeling, would there also be now a point in time to actually calculate all the different strategies, also in terms of what the actual demand, for instance, for endoscopy would be? Because otherwise we have a fair chance that we will be completely overwhelmed and then subsequently cannot deliver.
No, these are good questions. Thank you for the plug for more modeling. Absolutely. It's not clear. For example, when MRCP came out, some of the people said, well, that's going to get rid of ERCP, and we saw the inverse, right? Because more positives that led to ERCP. So it could be. The concern for example, colon cancer is that people will stop doing colonoscopy if they have a negative and if it's a false negative, like false reassurance. Less of an issue with false positives because, we already experienced that with Cologuard where there's a high level of false positives, but we can kind of put that issue to rest with the colonoscopy. But as I mentioned, and that's why the luminal GI cancers, it's a good place to start because we have a very good confirmatory test. But, the caution, and I use ovarian cancer as an example, the disutility of someone who's told that they have a positive signal for ovarian cancer. And you can't really tell them with confidence that they don't. And the disutility that causes. Anyway.
Yeah. Rob? Yeah. Just one comment about that. About the whole project in Molina, we started solving the waiting list because otherwise you are going to overwhelm the capacity of your endoscopic room. So after that, we are going to perform, and we are doing now, the blood test with the percentage of patients that will require upper endoscopies according to the capability that we already have. So if we expand the capacity of EGD in our unit, we are going to be able to expand also the serum blood test. Otherwise, we are going to be giving higher expectancies of the population of an access to EGD that we are not going to have. So I completely agree with you. So this is the way we are solving this problem.
Thank you, everyone, for the wonderful questions. I'd like to give a round of applause again to our speakers.